I'm John Higgenbottam, co-chair Canadian Alliance on Mental Illness and Mental Health, CAMI. I'm going to begin by discussing the impact on individuals and society of mental illness, including the economic impact. I'll be followed by my colleagues in the webinar, and then later I'll return to discuss secondary prevention opportunities to mitigate the long-term costs and consequences of serious mental illness. In terms of the prevalence and incidence of mental illness, 50% of Canadians will have mental illness in their lifetime. The remaining 50% have a friend, family member, or colleague who will have mental illness. So mental illness affects all of us. About 20% of people with mental illness have a concurrent substance use problem, drug or alcohol problem. In some communities, this may be as high as 70%. The incidence of schizophrenia is 1%, major depression 8%, and anxiety disorders 12%. Who is affected? 70% of mental health problems and illnesses have their onset during childhood or adolescence. Young people aged 15 to 24 are more likely to have mental illness and or substance use disorders than are other age groups. Women are 1.5 times more likely to meet the criteria for a mood or anxiety disorder than are men. Canadians in the lowest income group are 3 to 4 times more likely than those in the highest income group to report mental illness. I'd like to thank Louise McRae from the Public Health Agency of Canada for this and the next slide. This slide shows the medically diagnosed mental disorder crude prevalence rates for the years 2008-2009. By prevalence rate, we refer to the proportion of individuals in the population who have the disorder. If we look at the age group 40 to 44, we see that the prevalence rate for females is 19.9%. That's virtually 1 in 5 females have a medically diagnosed mental disorder of some sort. We see that for males it is significantly less, it's 13%, but it's still a very high proportion of the male population have a mental disorder. If we look at the elderly age groups 85 plus, we see that the rate for females jumps to 28.5% and for males 23.6%. Looking at the next slide, we see medically diagnosed mood and anxiety disorders within the population, and this refers to the proportion of people who have either a mood or an anxiety disorder. Together that would constitute the majority of diagnosed mental disorders. Within the 45 to 49 age group, again we see the gender difference with 17% prevalence rate for females and 9.6% for males. Again, these are very, very large proportions of the population who suffer from either mood or anxiety disorders. And again, we see the significant gender difference between males and females. The costs to society of mental illness are absolutely enormous. In Canada, mental illness is the second leading cause of disability and premature death. On any given week, at least 500,000 employed Canadians are unable to work due to mental illness, including approximately 355,000 disability cases, which are due to mental and or behavioral disorders, as well as approximately 175,000 full-time workers who are absent from work due to mental health issues. In terms of the cost to society, $51 billion is the estimated cost of mental illness to the Canadian economy in terms of health care and lost productivity. $34 billion is the cost of mental illness and addictions to the Ontario economy. And according to the World Health Organization, depression will be the single biggest medical burden on health by 2020. It's John Higgenbottam again, and I'd like this time to focus on some secondary prevention opportunities to reduce significantly the personal, social, economic costs of serious mental illness. There are major opportunities to reduce these costs, and I'm going to focus on three approaches which are evidence-based, as effective, and cost-effective. We'll begin by looking at assertive community treatment, or ACT teams, followed by a very brief look at crisis resources, and then we'll finish by looking at supported housing opportunities to reduce the costs of serious mental illness. Assertive community treatment was originally termed assertive case management, and it's an approach which was developed during the 1970s by two clinicians, investigators from the University of Wisconsin, Leonard Stein and Marianne Test. Its explicit purpose was to stop the revolving door of repeated psychiatric rehospitalization. ACT features an interdisciplinary team approach where an entire interdisciplinary team, including psychiatrists, social workers, psychologists, nurses, occupational therapists, vocational specialists, people from other disciplines, work together as a team to provide an integrated approach to clients in community settings. It has a low client-to-staff ratio, 1 to 10 is ideal, and it focuses on providing services within the community rather than within clinics. Assertive outreach is a critical feature of ACT, where you take services to the clients rather than basing them in clinics. Experience is that many clients with serious mental illness do not attend clinics, do not keep appointments, and it's important to take the services to them rather than expect them to come to the services. ACT focuses on symptom management and dealing with the everyday problems that clients experience living in the community. The team must be readily available to meet client needs in times of crisis, and the team has to be able to provide services for many years, perhaps the entire lifespan of the client. These cannot be time-limited services. Typical ACT team admission criteria include frequent psychiatric admissions, frequent use of emergency rooms, homeless or unstable housing, treatment non-adherence, dual diagnosis or concurrent disorders, legal problems, and discharge from long-term hospital. These slides have been made available by Dr. Ian Musgrave, a psychiatrist in Victoria. Dr. Musgrave has set up several ACT teams in the Victoria area, and the slides show you the results in terms of the reduction in psychiatric bed days with the establishment of the ACT teams in Victoria. So the first slide shows a comparison of 1 year pre-ACT teams admission and then 1 year post-ACT team admission, and you'll see that there is an 83% reduction in the number of psychiatric acute care bed days with the implementation of ACT teams in Victoria. This is with a 128 clients who previously had very high rates of rehospitalization for their serious mental illness. Looking at the results after 2 years, there is a 93.3% reduction in psychiatric acute care bed days with the Victoria ACT teams. So what we see here are very dramatic reductions in the use of psychiatric acute care beds with the implementation of ACT teams with this group of clients in Victoria. This slide shows the number of psychiatric acute care bed days by individual teams, and you'll see that the pattern of very substantial reductions in the use of psychiatric acute care bed days is present for each of the 4 teams in this. With the second group of 4 teams, we see the same pattern of very significant reductions in psychiatric acute care bed days for each of these teams, ranging from a 71.8% reduction in bed days to a high of 94.2% depending on the team. Another opportunity for secondary prevention is with crisis response emergency services. These can take a number of different forms. One example is a mobile crisis team called Car 87, which operates in Vancouver. And it consists of a police car with a police officer and a psychiatric nurse who travel to clients who are in crisis and try to deal with the crisis right where the client happens to be and prevent a hospital psychiatric emergency admission. Crisis lines are also very useful in terms of reducing hospital admissions. These are lines that clients can call and receive counseling or advice, and again are quite effective in reducing an actual emergency hospitalization. Crisis beds are beds often set up in houses in the community which are used as diversions from psychiatric emergency units, and these are also very effective in terms of diverting or reducing acute psychiatric admissions. I refer to a program by the name of CREST, which operates in New Westminster, and CREST seems to be diverting about 30% of potential emergency psychiatric admissions from Royal Columbian Hospital. Very, very effective program and very cost effective. Another major opportunity for secondary prevention with people with serious mental illness is through providing supported housing. A good example of this is a program in Calgary operated by the ALEX called Pathways. Pathways provides housing and support with a 24/7 assertive community treatment team approach at a cost of $34,000 per client per year. This is a total cost including housing, furnishings, support team, as well as administrative costs. This may sound expensive, but the savings per client per year on average have worked out to $50,000 to $70,000. There are other savings additionally through reduced contacts with emergency medical services, the Calgary Police, acute care services, and corrections. So key partners in Calgary recognize the value of this kind of collaborative approach for both the client as well as cost savings to the system. A good example of what can be achieved with a program like Pathways is Walter. Walter is a 47-year-old male, and prior to Pathways had been on the street for 5 years. Walter has multiple health concerns. He moved into Pathways September 2008. In 2007, his costs, including hospital costs, walk-in clinics, and emergency room treatment, were in excess of $55,000. In 2008, prior to being admitted to Pathways, his hospital costs, walk-in clinics, and emergency room treatment were in excess of $121,000. Since he's been admitted to Pathways, he's had a single emergency room visit which cost $500. This shows that secondary prevention programs like Pathways can very significantly reduce the personal, social, and economic costs of serious mental illness.